A very good morning to all of you. I'll be speaking on the supranuclear and central eye movement disorders, a case series, no financial disclosure. The aim is to describe the clinical features of supranuclear and central eye movement disorders, which are a rare group of eye movement abnormalities and the factors that aid in the diagnosis. So it's a retrospective observational case series of 14 cases from a tertiary hospital in South India over 6 years. Standard neuro-ophthalmic and neurologic examination were done, and the cases were managed conservatively. These were the cases, and the age group ranged from 8 to 75 years, and various diagnoses were found. As you can see, the majority of the cases were internuclear ophthalmoplegia, but we did have other cases as well. So why I want to highlight on this is that we all know the PPRF, RIMLF, interstitial nucleus of Kajal, and all those things, and they are present within a very small area of the midbrain and pons, and rarely we get clinical the diagnosis picked up on the MRI. So they just give lesion around thalamus and all, but we cannot pinpoint that particular area. So this is a case of internuclear ophthalmoplegia, left abduction, everything is normal. As you can see here, left eye adduction is abnormal, and there is a abducting nystagmus on the right side. So again here, the imaging just bleed around thalamus, midbrain, that's the kind of imaging that is given. Ideally, we need a functional MRI, but many patients, many centers are not equipped, patients may not afford. So clinical examination to pinpoint the diagnosis is the crux of treatment. And here again, this is a patient with hypertension with multiple bleeds intracranially, but again the diagnosis does not get pinpointed, and it's a case of vertical gaze palsy. And this is another patient, known hypertensive with vertical gaze palsy. As you can see, it doesn't move up and down. Horizontal movements are also limited to a certain extent. So the upper lid retraction is also seen in this case. And this is an 8-year-old child with dengue encephalitis, and here you can see the convergence retraction nystagmus. That's a very rare thing to see. And most of the time, these things are missed on diagnosis unless we know that this is a thing. Even he had squint and like it was very differing at different points of time with limited extraocular movements. So here again, he had some signal intensities noted in the medulla and the pons. This is another child with SLE who was studying in 10th standard that time and had problem with reading. And here also there were micro bleeds around the pons and the middle cerebral area, and you can see her convergence is perfectly normal. She can see the convergence, she can converge, but when we are putting on the accommodation, the near vision, that is when she finds it abnormal. And then again, when we put the glasses, she can get her near point of accommodation closer. So this is our house surgeon with the divergence insufficiency who was treated with the base out prisms. So to conclude, understanding the complex eye movement disorders helps us in localization of the lesion in the brain, because most of the time the imaging that we get will not give us, will not pinpoint us to the particular diagnosis, and it is, although it's an era of investigation, I feel it's still coming back to the clinical examination where we have to pinpoint the lesion. Again, it is very, very different to tell within that small 1 by 1 centimeter area which particular center it is. Is it RIMLF, is it INC or PPRF, like that? But it's important for us to understand. The treatment, however, is conservative, and prisms sometimes and glasses, as in this last case is given. For most of the other patients, it's mostly observation. Many of them are debilitated also. These are the references. Thank you.
Follow-up, you prefer videography or photography? Which one, as per your choice, which one best?
So generally I take videos and photos, because many times I feel I may not have understood what is exactly happening to the patient, because we do not know everything. So if you have a videography, you can again go back and check.
In all patients, you are preferring videography in such complicated cases?
Yes, so most of all the patients I take video, and as somebody else also mentioned, since we also don't have the IR photography, most of the times for the measuring the pupil, like in the accommodation insufficiency girl, she did not have the pupillary involvement, which was very surprising. So that will fix our diagnosis only to the ciliary muscles, and it spares the pupil, but only the ciliary muscle is getting affected, and it rules out ADs also. So I also take readings either on when we didn't have. Yeah.
As it is a competitive, I'm asking one
Right,
question. What are the advantage of videography over photography?
Even nystagmus and all, we can slow
Yes,
and
one.
check. So I did get one Fresnel goggles. Like I did not have Fresnel goggles, but I just made the optometrist do a 20 power glass.
Fine.
And
Technically,
check.
one advantage is that we can freeze it and we can use
Yeah,
it
we
as
can
photography.
freeze,
We
do it
can
in slow
freeze
motion and
slow
then
motion freeze and we can
recheck.
do that one.
Yes.
That's very, very important.
Yes,
And
sir.
yeah.
You said you had a patient of accommodative insufficiency.
Yes, ma'am.
And you found the lesion?
Ma'am, the MRI gave the lesion as pons and
Pons,
MCP.
I think this accommodation should
Yes,
not
ma'am.
be there.
It is under
Pons,
in the MRI. It was given like that, ma'am. But that's what she had.
exact
SLE.
accommodation center is not known, but
Yes,
there's a
it
triad
Yes,
of
yes.
neuroreflex.
Yes.
So
She had multiple bleeds in the whole of white matter. Like pinpoint bleeds were there.
yeah, there might be a micro
Some
bleed
micro
over that
bleed
area
over
of the third nerve
area
nucleus
which is
area.
Accommodation center.
And divergent insufficiency is also very difficult to diagnose
Yes,
clinically.
ma'am.
So what were the features in that patient?
Ma'am, he was our house surgeon who started developing a sudden onset diplopia, mainly for FAR. So initially suspected any mild 6-nerve paresis like that, but then the deviation for FAR near I checked.
Esophoria was there or
Only for
esophoria?
FAR, ma'am. Yeah, he had
Esophoria.
a 6 diopter esophoria for distance and normal for near, ma'am. And eye movements were normal, no papilledema, no raised ICP, MRI was normal, so I put it as probable divergence insufficiency.
And your convergent retraction nystagmus patient,
Yes.
when the patient was looking up, there was retraction of the globe,
Yes,
but
that
no
is,
convergence was there.
Yeah.
In fact, the eyes were diverging
Yes,
more.
yes. He had a exotropia also.
Okay.
I put the
Okay.
picture. He had a exo and
Okay,
this.
good.
Thank you so much.
Nice.